Technical section, finding and generating quality data. As with any kind of change, it's important to have data. With the right data, we can determine which parts of our process are most problematic, or hotspots, validate that our approach for changing things is working, and compare products or processes to use better ones. Climate metrics. For climate change and greenhouse gases, there are multiple approaches for gathering data depending on what scale you want to know about emissions. A life cycle assessment, or LCA, summarizes the emissions of a product or process across its life cycle, from raw material extraction through production, use, and disposal. It's great because you can quantify multiple types of emissions, not just greenhouse gases, and it's a scientific approach with international standards to follow, ISO 14040 or 44, or 14067 for just greenhouse gases. It generates relatively simple numbers. It aggregates emissions into a single unit. GHGs are often reported in kilograms of carbon dioxide equivalents, which can help with decision making and marketing. It's flexible depending on the types of questions being asked, and the results are based on the function of a product or process, allowing better comparisons between multiple products. Of course, like any tool, LCA has some challenges, including with different databases and methods. It can be hard to compare two products which were analyzed in two separate studies. LCA is largely determined by the assumptions made by the practitioners and the quality of data they had, so having a complete understanding of a product's results requires a lot of reading. It's a model that can be hard to validate externally. We can't put a really big bag around a whole production system and actually measure the GHGs emitted. That said, LCA is a powerful tool that has been used in many industries since the 1970s and is increasingly being used in healthcare. Note, input-output LCA models, EEIO-LCA or EIO-LCA. The approach to LCA above, initially described here, is also called process LCA. A process LCA uses physical data to estimate greenhouse gas emissions, including kilograms of materials or kilowatt hours of electricity. These are often called unit processes, or the smallest unit of measurement of a system. A separate approach uses financial data, and this was developed to create a more comprehensive analysis that has broader scope and increases specificity with use of physical data. These input-output models, sometimes called economic input-output EIO-LCA or environmentally extended input-output EEIO-LCA, are very useful for large systems, like a nationwide emissions estimate. EEIO or financial models are not very useful for product-level assessments, as the level of aggregation in the estimates are high. For example, a glove and a laparoscopic cautery device are in the same economic sector in the model, meaning that the kilograms of carbon dioxide emitted per dollar are the same. So the only differentiating factor in their greenhouse gases is the dollar spend. In US healthcare in particular, these dollar financial-based models may be even more challenging, as prices for medical devices and services can be artificially set, as in not related to the amount of money required to make it. Therefore, EEIO models should be used with caution, especially where detailed assessments are required. Overview, organizational level greenhouse gases. LCAs become increasingly difficult the more components are included in a process, or the more multifaceted the process becomes. If there's no clear function, it may be best to switch to a different methodology. One commonly used approach for businesses and organizations is the Greenhouse Gas Reporting Protocol, which has been mentioned in previous sections. Refer to those sections for a refresher on the three scopes and what each entails. Tools for greenhouse gas reporting. If you are interested in learning how to do a product level LCA, there are online resources, such as a class that we teach, generic online and in-person courses, and a free online LCA textbook. Healthcare Without Harm, an organization working on cleaning up the health sector, has also released a hospital-level tool. This is very handy for those with Healthcare Without Harm membership, with a caveat that it uses spend-based or those EEIO-LCA models, like most tools at an organizational level, for Scope 3 emissions. So procurement decisions need to be carefully thought about rather than relying exclusively on this model. Outsourcing LCAs or GHG reporting. A major debate for many organizations is whether the measurement expertise should be held in-house or outsourced. Reasons to keep expertise in-house: insourcing offers more control, better collaboration, and tailored solutions, but may involve higher costs and limited expertise. Reasons to outsource: outsourcing brings cost savings, speed, and access to global talent, but can affect quality control and flexibility. Other metrics for resource consumption data. An LCA or GHG report can be a large time or monetary commitment for an organization, and sometimes people can be distracted by obtaining the most perfect data rather than acting on what they know. There have already been a large number of product-level LCAs done, so there is no need to avoid acting in order to get another LCA or more detailed data. It can still be helpful to have some data or metrics to monitor success of various interventions, and generally speaking, reducing any of these things is likely to reduce your GHGs as well. Some data that can assist in monitoring and also be used to conduct an LCA or GHG assessment include energy metering, water or other utility metering, waste audits, medical gas purchase records, and procurement or spend data. Energy and utility metering. These data would feed into a hospital's Scope 2 emissions, and it's relatively easy to obtain. As most institutions purchase electricity and other utilities from another business or the government, there should be a record of how much was consumed, kilowatt hours of electricity per month or meters cubed, cubic meters of water per quarter. Keep track of this and start assessing seasonal changes or other fluctuations. Sometimes interventions will be visible in this aggregated data. For example, all lights switched from incandescent to LED should show a noticeable shift in total kilowatt hours consumed. When renovating a building or constructing a new building, consider adding in submetering of your various utilities to get more granularity on where resources are being consumed. If more granular data is needed than a system or hospital-wide bill, consider adding temporary metering equipment to elements of your health system. Recent studies of radiology units have attached meters to MRIs and CT imaging equipment to better understand energy usage of those machines. Doing this will require approvals from a few different departments and may require hiring a technician or company to install and deinstall the meters. Waste audits. Solid waste generation is another data point that can help health system managers better understand consumption of resources. Most often, waste data would feed into Scope 3 emissions estimates, both for procuring that garbage and for disposing of it. Hospital-wide waste data may be available from the waste haulers contracted by the health system for each waste stream. Manifests should be kept showing the total quantity of waste removed from the site, and the haulers will know how the waste was transported, where it went, and what its treatment steps were. Of note, some haulers are better at record keeping than others. Some may still be keeping track of things with a pen and paper. If more detailed data is required, a manual waste audit might be the path forward. This might mean weighing total trash from the different waste streams, leaving a clinical unit, or it could be even more detailed, requiring people to dig through the trash and sort it. Detailed waste audits can provide really interesting data, including average amounts of waste generated by unit, procedure, care team, provider, etc., types of material disposed in each waste stream, like plastics or paper, success rate of sorting or diversion initiatives, how much red bag waste was in the white bag, any non-recyclable items in recycling, etc., and the amount of unused, unopened, or partially used items, unnecessary waste. These data can help create a greenhouse gas profile, but they can also inform interventions. Perhaps bins need to be resized or relocated. Perhaps staff need a retraining on proper waste sorting. Perhaps new waste streams could be introduced to divert items from landfill. Perhaps housekeeping needs new stocking protocol to prevent unused items from being wasted. A detailed waste audit can inform all of this. Medical gas and supply procurement financial data. Depending on how detailed the record keeping is for your institution, you may also be able to utilize procurement or purchasing data for medical supplies and devices, including medical gases. These data could include spend and quantities of materials. Procurement data should be critically assessed and may pose the following challenges. Contract secrecy. Sometimes procurement data can feel harder to get than patient health information. Procurement departments often sign contracts that forbid the health system from disclosing their pricing. Thus, they often heavily restrict access to the data. If you are not in a position of authority to simply demand the data, you could use the following tactics to access the data. Specify the use for internal quality improvement only, and if external reporting is expected, aim to maintain security through aggregation of the data, such as medical supplies cost $13,000 rather than gowns from vendor X cost $2, etc., which would not violate the supplier contracts. Data organization and maintenance. Some institutions may barely keep track of purchasing at all. If you are lucky enough to be in an institution that keeps good electronic records, rejoice. For others, this may be a separate issue to tackle. Data quality. Another issue in supply record keeping is that order quantities can vary. For example, glove purchases could be recorded by number of gloves, boxes of gloves, which are about 250 gloves per box, or cases of gloves, which are about 25 boxes per case. Sometimes it is a challenge to properly sort through the institution's data. Supply procurement versus management. Health systems that track spending might not always track where the supplies go once they are ordered. The data may be aggregated at the health system or department level, meaning that you could see that the supplies ended up in a central warehouse, was ordered by a department, or perhaps was stocked in a certain unit. Depending on how you intend to use the data, this may not give you enough clarity to track outcomes of sustainability interventions. For example, if you wish to implement a waste reduction initiatives for a supply item on an inpatient unit, but the health system doesn't track deliveries beyond their central warehouse, then your initiative might not show up in the available data. If this is the case, you might consider other means of tracking, either by creating a better supply management approach at your institution or conducting waste audits instead. Prices can change. If relying on supply prices as a metric, know that cost per item can shift based on contracts and market forces. Spending less doesn't always mean you've reduced consumption. Social and cultural data points. In addition to hard data points, it may be useful to track data related to how people interact with your initiative. Sustainability policy adoption, like the number of policies as well as the number of departments or people they touch, could be a metric. Employee engagement in sustainability programs, leadership commitment to sustainability goals, and integration with quality improvement initiatives are all examples of this.